especialista en psiquiatría, profesor titular de psiquiatría clínica, jefe de formación académica del Departamento de Psiquiatría de SUNY Downstate Medical Center en Brooklyn, New York. Es autor del libro Why Physicians Die by Suicide y de otros textos. Welcome, Dr. Myers.
Thank you and good morning. I wanted to start by just telling you about an initiative in our country, in the United States, National Physician Suicide Awareness Day. This was started back in, 2018, and it was started by a group of emergency physicians who had experienced an unusual number of deaths by suicide in their residence as well as in their faculty. And that's the group, the Council of Residency Directors in Emergency Medicine. And over the years, it has built tremendously and is now being observed in a lot of other countries. And for instance, this past September the 17th, which really was just a couple of weeks ago, I took part in a couple of virtual, well, one virtual and one in person. The one at Columbia University was in honor of Dr. Lorna Breen, where she had worked. I mentioned her yesterday. And that was with several speakers. There was a moment of pause and that. And then I sort of ran from that to our own session, which was, well, live for us, but on the internet. We had a speaker who is a retired urologist from California, Dr. Bill Lines. I've come to know him over the years as a survivor of multiple suicide attempts. He's been very healthy now for some years because his diagnosis was changed from major depressive disorder to bipolar 2, and he's on a good regimen with his psychiatrist and that. So, but I bring this up because it really is such an important day, because it is a day that we do remember and we pause and reflect, and it's a solemn day, but it's not really a sad or depressing day. It's always full of hope and collaboration and where we're going, and I think it's very important to remember that, because there are people who obviously kind of run away from this subject because it's a very serious one, but yet it is a reality, and there is so much that we can learn. So I'm hoping by the end of our time today that you'll have a better sense of some of the illnesses, as well as some of the various stressors that we wouldn't put into something like DSM or ICD, but yet can come together and render somebody in medicine suicidal. I'm going to talk quite a lot about stigma, because even though the term is banding around a lot, there are so many levels to it that are really very critical. And then a skill set for reaching out to somebody who is in distress. So just to start with this was just a review. This became a very important paper because it was the first time in some decades where we had a sense of the numbers of physicians, first of all, who had died over a period of 14 years in US training programs, and really what they died of. And so the number one cause of death overall were neoplasms, and then the second leading cause of death was suicide, and then after that, accidents and other types of deaths. With one distinction, that when it was broken down into gender, death by suicide was number one for men, and death by neoplasms was number one for women in medicine. So the other important finding of that 14-year study was the vulnerability of the first 3 months of training. And that's very, very important that we really give a lot of thought to that. And I was kind of hinting at that yesterday. when we talk about transitions of our incoming residents, say from medical school or perhaps from another residency into psychiatry, that's a time when all efforts really have to be made to make sure that that can be as seamless and as welcoming and as healthy as possible. And when I spoke yesterday about my mentee, Dr. Kaldokar, he's an example of someone who really tragically fell through the cracks. And by the way, before I forget, one of the other things that can happen in that first 3 months, and I've always been very, very sensitive to this, was in my private practice when I was looking after, say, a graduating medical student who was leaving me because he or she was moving on to another part of the country to do their internship. I was always very conscious of the fact that they have continuity of care, because even though they were stable at that time, their follow-up was extremely important. And so I would always arrange to have a colleague in place in the receiving city where they were now transitioning from medical school to their internship, their first year of residency. Because there's a lot that happens at that time, because the individual usually is feeling quite stable, and even given, say, 1 month of medication to carry them through until they have that first appointment at the receiving end. There's so many things that happen that the individual is doing well and is so busy that the prescription runs out, they get busy and then may not keep that first appointment. And the new person doesn't necessarily know perhaps the importance of that. And basically things go okay for a while. And sometimes for a long while, but sometimes for a short while, where they begin to then get a recurrence of symptoms, and there's sort of loss of insight, and they can descend into a frightening space of a recurrence very, very quickly. And so that's why that time needs to be managed very, very well. So, and you know, as therapists and psychiatrists, we walk a fine line between being careful and not being an alarmist. Because at one level, you know, they're excited. They don't want to be scared that this is all going to come crashing down on them. So these are just some tips having to do actually with what I would call hygiene. Okay, so fast forward now from when that paper was published until just this past year. And what they tacked on now was another 6 years of follow-up of what's happening in residency programs. In recording the number of deaths, neoplasms had dropped and suicide had become the #1 cause of death in this cohort over this 6-year period. The other thing that was reinforced, again though, was that first 3-month period of training that remained a vulnerable period of time. And so part of the outgrowth of this is to just once again kind of highlight the emphasis on this vulnerable time. This piece, I wanted to mention this because this was something that was published in 2024 in the British Medical Journal, and the authors admit that this is a study with a number of flaws. But why it was important, and there have been another one since, is a concern that, and I touched on this yesterday, that the deaths of men in medicine as physicians have actually dropped somewhat, which is obviously a good sign. They're more in keeping with men in general, but those deaths by women in medicine have not, and that was borne out in this paper by Zimmerman and her colleagues. So that was just a reminder about that. So let me now just go to talk about some of what I like to call suicidology 101. And this is not specific to physicians, this has to do actually with individuals in general. That we've long felt that roughly somewhere between 85 to 90% of people who die by suicide have been living with some type of illness, although very often it hasn't been recognized. If it's not recognized, then obviously it can't be identified and treated. And so psychiatric illness is considered really the major driver of suicide. So But I've always been curious over my many years working in suicide, who are these other 10 to 15%? We can talk more about that later, but I just wanted you to remember that indeed there are individuals where after their death, their family, they say quite vocally, look, we're not a family that's in denial at all. Our son or our daughter or my husband did not have a psychiatric illness and yet died by suicide. So this is a group that is really still, because there's been, I think, an unfortunate and I think often inappropriate effort sometimes on people in mental health to not accept some of these families' narratives. And these individuals have felt that alienated from us. So it's just an example of something I think where we really have to be very careful about the arrogance sometimes that comes from our training and study. Okay, so they're undiagnosed, they can't be treated, and the box at the bottom is very, very relevant to physicians. And why I say that is because I've seen the whole works here of doctors who've had a diagnosis, but they certainly are untreated. And my postvention research, which I'm going to mention in just a few minutes, has borne that out. Okay, so those are the ones that are untreated. Then there's the ones who are undertreated because they don't really want to be a patient, and the person looking after them really doesn't want to look after them either. It's kind of an awkward dyad that they're each kind of cutting corners to try to get this person feeling better again fairly quickly. But they end up, though, with inadequate care. So then there's the self-treated ones, and those are the doctors who don't go to see anyone other than themselves. And they're legion. There's many, many out there, including many of our fellow psychiatrists who self-treat. We can talk about that later if you like. And then they're the ones who are actually mistreated. Again, where a lot of mistakes are made because the person it's a mix. It's somebody trying to treat somebody who's also kind of self-treating. There's no chart made up on the person. It's just, trying to get feeling better or whatever, but it just really becomes risky and dangerous. All right. So what about some of the underlying illnesses? Now this is very straightforward. The number one is mood disorders. And especially the higher risk occurs, of course, in bipolar illness. And this is why it's so important to make an accurate diagnosis of whether it's bipolar 1 or bipolar 2, for one thing, and obviously getting a very strong family history of that. The second one I put down is possibly burnout, because the jury is out yet. There are camps that say you can have pure burnout leading to death by suicide. Others say, no, there's got to be intervening stuff and comorbid stuff or whatever. And that's largely an academic and scientific discussion. At the end of the day, I think what's most important is to obviously always keep this in mind and don't minimize the massive extent of burnout in a physician. Anxiety disorders, those of you like me who have been around for a while, we can look back and think that this was actually sort of underdiagnosed. We know much more about anxiety disorders now and how they have to be properly treated. Substance use disorders, I could put that up probably as number 2, because so often substance use disorders are comorbid with mood disorders, because when individuals are depressed, so many of them self-medicate, especially with alcohol. And in younger physicians, often cannabis and sometimes other street medications. And post-traumatic stress disorder, that's been another one that if we look back, those of us who have been around a while can probably see where we actually missed a diagnosis of PTSD in some of our physician patients. Now, where that comes from is because I think until about 20 years ago, except in the military, physicians who were military physicians, there was a tendency to play down trauma, the impact of trauma on physicians. We were all just expected to be tough and strong. And so therefore you kind of sucked it up. But what actually happened was that many of those individuals resorted to chemicals. And when I began to see this so vividly was in my private practice, when doctors would be referred to me after they had been sort of clean and sober for about 9 months, but now we're coming with a recognition of having symptoms of an untreated PTSD that had been there for a long time. But nobody knew they had it, including the physician, because of their use of substances. And then don't forget progressive and unrelenting medical disorders. There is a cohort of doctors who die each year who are living with the ravages of a progressive medical disorder. Now, they may have developed depression associated with that, but it's been what that's been like for them that has been really so very difficult. And those are the physicians as well who become very, very interested in medical assistance in dying, because they know the prognosis and they're very clear that they don't want to go to that degree with the disorder and therefore do become suicidal. And then, of course, personality disorders. You know, physicians, we're all through DSM. There's every personality disorder actually can apply to a large group of physicians. But the three that stand out and can put doctors at risk of suicide with something on axis 1, using the old terminology, are antisocial personality disorder in doctors, as well as narcissistic and borderline. Those are the three main. So there's no one type of suicidal action. Even this one is not all suicidal, but certainly the ones, though, and you're going to see a clip in just a minute, of somebody where this was a process that it began slowly and kept building and building and building. And it can be over several weeks, sometimes several months, in some people's case, sometimes years. And it is, you know, we, in the world of suicide, would say it's never one thing that drives somebody to that final act. It's a confluence of things coming together all at one time in this so-called horrific storm, which can be absolutely enveloping and just really takes over the person's life. And that's when, of course, it's very, very dangerous. But it is biopsychosocial in all respects. The last bullet, I wanted to just explain that, because what that is are the individuals that I've looked after, and perhaps many of you in this room have as well, who are suicidal, but not imminently or dangerously suicidal. But suicidal thinking is part of their everyday functioning. Those are the physicians who want to talk with a mental health professional about that and have difficulty sometimes finding a mental health professional who will go there with them because of the fact that they've tried this before and they felt that the mental health professional panicked, freaked out, put them into hospital when they didn't need to be in hospital, and that was very traumatizing. So what I'm getting at are those individuals who want to talk about that very dark part of themselves and really need the assistance of somebody who's experienced and is able to tell the difference between somebody who's struggling with this but is not at imminent risk of hurting themselves, that type of thing. So that's a very important thing. And I've looked after so many doctors like that on an ambulatory basis. And many of them will say that. In fact, they will say to me, "Don't you even try, Dr. Myers, to take my suicidal impulses away from me." And I'm not even ready yet to tell you the details of my suicide plan that I have up my sleeve. These are individuals then that I do ask them, "Do you have a date with death?" And they look at me and they can tell I've been around the block, around the corner, and they say, "Yes, I do actually." I said, "Do you mind sharing that with me?" "Not today, maybe next week, if you'll have me come back, or if I decide to come back to you. See, when somebody talks like that, you can tell that they're kind of beginning to build a relationship with you, and they're not quite sure yet of the therapeutic alliance. And so you're both doing a little bit of a dance with each other. I'll say, I hope that you do. I'll do my best to see that type of thing. Anyway, we can talk about that more, but that's a very, very important, because these are individuals, when they get through that process with you, I cannot tell you how healthy they feel, that that's the end of their suicidal thinking, that they didn't end up attempting suicide, they didn't die by suicide, and they feel a much healthier, more integrated individual, because that's all in the past. This is the story of Dr. O, 2 minutes.
You know, it was a process of spiraling. And I think over the course of several months, you know, I couldn't eat, I weighed much less, I couldn't sleep. I was getting panic attacks, I was very, very tearful. And there was a growing feeling of feeling hopeless, you know, that just wasn't. You know, it was a process of spiraling. And I think over the course of several months, you know, I couldn't eat, I weighed much less, I couldn't sleep. I was getting panic attacks, I was very, very tearful. And there was a growing feeling of feeling hopeless, you know, that this just wasn't going to work, that it wasn't worthwhile going on. And the feeling that comes is a feeling that you feel alienated, you feel as though you're outside the world. And one of the saddest things, actually, when you're depressed is you look at other people doing normal things and you just, you know, you just can't relate to it. Like you feel you give anything just to be like that. Even, you know, when you watch people going like to the grocery store or something like that. So basically I was feeling like that, but it got worse. I mean, I didn't think it could get worse. And at that time I felt, you know, like I wanted to kill myself. And then it was almost as though it was automation. And I took a bunch of pills. It just got gradually worse. And I remember the evening that I did take the pills, I was by myself. It was so painful to be like that. It was physically painful to be alive, almost. And the feeling that, Christ, you know, this go on forever. You know, I'm going to be here for another hour, another 2 hours. I mean, it was just too much. It's hard to reach out to anyone because part of depression is that you feel so bloody awful about yourself. I mean, you feel horrible, you feel physically horrible, and mentally you feel useless. And I think that when you're in depression, sometimes you confuse yourself as being flaky, as I say. You know, you don't realize that it's because something biochemical, something's happened to you.
I wanted to just tell you there's so many important messages in that short vignette. This is why I show it so often, because, you know, we can read descriptions of depression, but any of you here in this audience who've experienced depression yourself in the past will know, even if it wasn't exactly the same as Dr. O, you'll kind of though see bits and pieces of what she was really dealing with, how it kept building, like it didn't go away. And how that sense of alienation is, she would look out her window and see people going to the grocery store and feel, I'm not part of that world anymore. And then when she uses the term, it was like automation. And I took a bunch of pills. By the way, they were tricyclic antidepressants. She was under the care of a psychiatrist at the time. She said in hindsight, she kept trying to explain to him that she wasn't getting better, but he kept trying to, I think well-intentioned, reassuring her that losing your husband to another woman can be a very profound type of loss, and that was accounting for, the depth of her despair. But as she said, it didn't get better, and then she comments that it's almost a dissociative state for some individuals because they will describe that. I've interviewed a number of people who have made near lethal suicide attempts. So then she says, it's hard to reach out to anyone. Like, because I had asked her offline, because as you know, I'm not on camera, but I had asked her if she thought of calling her psychiatrist. And she said, well, it's hard to reach out to anyone. And I've had that happen in my own practice with my own patients who didn't reach out to me. And this is where we have to really watch our judgment, because you feel so awful about yourself, as she said. See, this is the pain and the power of depression that explains so much of this. And then she said, and she's a physician, and she was a psychiatry resident, but she said she just felt flaky. She said, you don't realize that there's a biochemical shift that's gone on. There's something wrong with my neurotransmitters. That stuff doesn't work when you feel so awful. So that's why, we talk to patients all the time, but when we really think about it, everything, it's just so powerful. Okay, so the symptoms of depression, all of that there, the interior stigma, living with a mental illness. Yesterday I talked so much about perfectionism. I won't go through that again today, but except to say that you feel you're letting so many people down. Dr. Bill Lyons, who spoke with us at National Physician Suicide Awareness Day, that's what he said, that he felt that he had let his family down, his colleagues down. He isolated himself from his urology colleagues for months and months and months. He just felt that he had failed them, that he had stained that branch of medicine by trying to kill himself. Isolation, et cetera, et cetera. Then this cognitive switch that you see in individuals who, when they're on the mend, and after feeling so ashamed, then they feel that I've been given a second chance. And again, I have a whole cohort of physicians I've interviewed, again, after near-lethal suicide attempts, who really become crusaders. They become very active in the lived experience movement because they feel blessed or fortunate. They've been spared because they know so many people who didn't get a second chance, that they're dead. And so their lives become almost mystical. Why was I spared? Then, especially as a physician, then am I meant to continue then to help others, now that I have my life force back and things like that. These are phenomenal people and recovering from something like this, something as serious as a suicide attempt. So, 3 known risk factors in us, okay? Toxicology. All of you who have been pre-medical students or currently are medical students, you learn so much of this stuff. So there's all of that. And then when you get into your clinical years and that you see what suicide attempts people have used, what has worked, what hasn't worked, that type of thing. I've listened to so many stories of doctors who say to me, and I'm going to do it right, trust me, Dr. Myers, I'm not going to botch it. I've looked after too many botched suicide attempts in my practice. As a psychiatrist, as an emergency doc, as a trauma surgeon, I've seen it. I'm not going to blow it. I'm going to do it properly. Okay, then the ready access to things. Physicians who are hospital-based, access to fentanyl, access to intravenous tubes, syringes, insulin, potassium chloride, toxic chemicals, things like that. Thomas Joyner is a very prominent psychologist who wrote a book, Why People Die by Suicide. And he sees us in medicine, as particularly certain branches of medicine, as having perhaps an exposure just because of our exposure to just so much trauma and so much stuff in life that we become almost sort of immune or inert, that suicide doesn't scare us so much or something. It doesn't. Anyway, that's part of this so-called trifecta. Again, perfectionism, the altruism. Those are the doctors who put themselves last. They give and give and give and give. all right? Self-neglect. Again, I say that without judgment. They're altruists. What about the doctors who need autonomy and control? These are individuals, you look at their life story, they've been fending for themselves since they were little boys and little girls. Came from families where their parents were not well or absent. They're used to kind of doing everything themselves, including their own health. Not easy for them to go to doctors, that sort of thing. Not easy to ask for help. It's hard to be a good patient. That's why I get very defensive of doctor patients when we're kind of criticized for being terrible patients. Well, maybe there's a reason, okay? So it's just hard to be a good patient. Look at our work schedule sometimes. Even then, I mean, I've seen somebody say, look, I'd love to be a good patient. When the hell am I going to go? You know, I'm working, 24-hour shifts or something like that. The culture of medicine. Touched on that yesterday, the hidden curriculum, all that stuff there that can be going on behind the scenes. Burnout, moral injury, we've talked about that a lot the last couple of days. And then the systemic pressures of our medical world. This is just a quick thing because it's fairly recent. I got kind of excited about this to know that this moral injury, that you can have that as an issue, and you can develop suicidal thinking and not have a psychiatric illness. So this could probably form part of that 10 to 15% of individuals who are struggling with moral injury in the medical workplace, where they're having to do things that really goes against their grain. As you know, many of you who were very active on the front lines in the early weeks of the COVID pandemic, when there was a shortage of protective equipment and things like that, that was an example of moral injury, or where individuals didn't feel supported as well, putting themselves at risk. Let me turn to stigma. This is overly simplifying. To the external stuff, that's out there, okay? That's how we're treated. Stigma directed toward us. The internal stuff is the stuff that we've grown up with. We've incorporated it in ourselves and growing up in a society where mental illness is seen as pretty ugly, pretty bad, pretty second class or whatever, including our patients, that sort of thing. And so it becomes incorporated into us, is basically that. I've written several blog pieces on this where you can get much more detail on that at some point on my website. So just one exterior one that I want to focus on, and that has to do with discrimination, of how we're treated discriminately. And that has to do with external others who discriminate against us because of psychiatric illness in us. And the most prominent example in my country are medical licensing boards. Again, I talked about that yesterday. They're getting better and better through the Dr. Lorna Breen Heroes Act and the work that they're doing in removing those discriminatory questions. But that's an example, though, where doctors are made to feel second class. We see it sometimes as well, though, in training programs when individuals who have been transparent and have disclosed that they've suffered from a psychiatric illness, and despite the fact that they've had supporting letters from their treating psychiatrist, they don't get accepted into the program. And it's rationalized, well, we've got stronger candidates. It wasn't really about them. But when we really look at that, there's one to say, it's got more to do with the fact that, look at, I don't know if we can really absorb someone like that. We had somebody recently, she had a lot of problems. She had to go on medical leave. It took her 6 years to finish the program. I don't know, we're just screening a little more carefully these days, that type of thing. So, a lot of work to be done there. So that's just a backup slide. There's three of us, three different groups, the gold group, Jones North. I'm part of that second group where we've examined these licensing things and have, doing lots of advocacy work. And then the Derby group, the Lottie Derby group, that's the Tate Shanafelt, the Colin West group. Their slides were showing this morning. Okay. So let's think about cultural groups for a minute, because we're kind of a multicultural group here as well. And these things do vary with our race. I know, like, the medical center in which I work prides itself on its diversity. And so therefore, any of our medical students, for instance, who are seeing the psychologist across the street, many of them who come from significant minorities have not told their parents that they're actually in care, because their parents, quote unquote, would have a fit. Because mental illness in their particular culture is seen as just so bad, and it doesn't happen in our family, that type of thing. So these are kinds of things that we just have to pay attention to. Much more stigma associated, like within the LGBTQ plus population. I know this from my own medical school, where the gay and lesbian students said, we don't have a problem with our attendees, they treat us fine. It's our trans medical students who are having more of a tough go, because there's just so many of their attendings who just don't get it. They said, you know, I can't get my head around this, that sort of thing. And if they're open to some continuing medical education, terrific. Unfortunately, too many of them aren't. But these are the things, though, if you're living with a stigmatized illness, it's a wonder you're not going to be the greatest patient, all right? You're going to kind of maybe play with your medication a bit, maybe not always follow your psychiatrist's orders or something like that. Or maybe kind of the pharmaceutical rep comes along and tells you about a drug that seems to be working faster and with fewer side effects, and you sort of stop the one that you've self-prescribed and start taking that one, that kind of thing. All kinds of things like that, all having to do with stigma. Okay. Now this is the interior stuff. Again, I wanted to just mention very quickly Dr. Sophie Spooner, because she was an example. I didn't get a chance to interview her during her lifetime. She died by suicide, but her parents have become vocal advocates for the importance of continuing care. And what their point is that when Sophie's diagnosis was changed from major depression to bipolar 2, and she was being appropriately treated, her psychiatrist, this was in the UK, they're so short-staffed that many of them are not able to provide continuing care. And she wasn't getting that from her psychiatrist and wasn't getting what I felt, the psychoeducation support that she really needed. And her life just began to unravel. She was engaged, she felt that she was unworthy to her fiancé. She felt that she worried that she wouldn't be able to have children because of the risk perhaps of transmission with bipolar illness versus unipolar into the next generation. Just this shame she felt about having an illness that can make you go crazy as opposed to one that makes you get sad, this type of thing, and didn't have access to support groups and things like that. So her family, her mom's a physician, her father is a businessman, they've been very active in the UK about making a change on this type of thing, and just how important it is when we convey these kinds of diagnoses that are correct, that the impact of that, though, in a young person's life can be really, really very difficult. We have to pay a lot of attention to that and be available. Felt stigma, denial of symptoms and behaviors. Why wouldn't we? Who wants to accept a stigmatized illness? Okay. We minimize our drinking, for instance. We rationalize it. Magical thinking. Anybody in this audience who has an overworked thinking, you know, maybe if I work a bit harder, some of these symptoms will go away? It's very common in doctors. We're hesitant to reach out. We're embarrassed, even in that consultation visit, that sort of thing. Have trouble making eye contact, blushing, and things like that. I wanted to speak just for a moment about Armour. I remember a cardiologist coming to see me. I had a separate office off-site, but I also had one in our teaching hospital. He preferred to see me, wanted to see me right at the teaching hospital because cardiology was just one floor away, and it would be quicker for him to come see me, then he could get right back to work. But I'll never forget, in the very first visit, he was sitting opposite me, white coat on, stethoscope around his neck. And about 3 to 4 minutes into the chief complaint at HPI, he was railing us up. He stopped and he looked at me. He said, Dr. Myers, would you mind if I examine your heart? And I kind of smiled, did a double take and laughed. And he laughed too, thank goodness. And I said, do you want to talk about that? And he said, it would be a hell of a lot easier than sitting here as a patient. 5 minutes ago or 7 minutes ago, I was a cardiologist. I'm not now. And that was his way of saying, work with me. This is gonna take a bit, that sort of thing. It might have been easier, actually, if he did see me in my off-site office, because he would have had 20 to 30 minutes to kind of get out of, the work persona into the patient role, that sort of thing. But it's very hard. Stigma, it's a lot better, but I still call it pernicious. It is higher than in the general public, and it discourages people from getting help. And it does heighten morbidity. That's why so many doctors, when they come to us, this stuff's been dragging around for quite a while. And so it's tempting to say, oh my God, why didn't you come here sooner? But you hold that in and just be pleased that they're there now. A conversation with a surgeon patient of mine. She began to wake up in the ICU. This was about an hour later. I did this as a role play when I wrote about this. Me, do you know where you are? She says to me, yes, I'm in an ICU somewhere. I say, correct. Do you know what happened? She said, I sure do. I took too many pills. I wanted to die, using the past tense. Then she corrected herself, I want to die. I say to her, I'm glad you didn't. I'm happy you survived. She looked at me, you are? I'll never forget that. You are? You're happy I didn't die? I'm so embarrassed. I feel ashamed of myself. I said to her, don't be. You're in a good place here. Nobody's judging you. The staff here just wants you to get better. Then she said, but I really blew it. What kind of surgeon can't even kill herself properly? Because I already knew her, she'd been my patient for several months, I took a risk and used some humor. Thank goodness it worked. Here's what I said to her when she said, what kind of a surgeon can't even kill herself properly? I said, I didn't realize that knowing how to kill yourself was a requirement of the American Board of Surgery. And I'm so glad that you're kind of smiling and chuckling because she smiled slightly and said to me, I can still see her when she said to me, good one, doc. Said like a surgeon. I'll never forget that. It was very so then I said to her, get a bit more rest. You and I have got a lot of work to do. Your depression is still there. It's got to be treated. We'll keep you safe here until you're feeling better. Okay. I mentioned the importance of having a primary care physician and making sure that somebody who's comfortable looking after you, that they let you be a patient. And which may be a little bit hard for you, but they'll help you with that. But that they're going to treat you like they treat their other patients, fully knowing, though, that you're somebody with some degree or a lot of medical training. All right. That study I'm referring to is my postvention study. I won't go into details about that, but that's my study of family members of doctors who have died by suicide. There are close to, between 15 and 20% of these families who lost a physician loved one to suicide where that person did not go for any care at all. They didn't go to a primary care physician. They didn't go to a psychologist, a psychiatrist. They didn't speak to anyone. They didn't go to the clergy. They went from wellness to illness to death. I've talked with doctors in other branches of medicine, and especially oncology, said, have you ever heard a doctor diagnosed with cancer who didn't go to an oncologist at least once? I said, no, they hadn't actually. So there's something there that either we've got to do a better job in terms of our PR or getting messages out there that we can help. Because there are a significant number of doctors dying by suicide each year who are dying of treatable and untreated illnesses. Concerned about a colleague? We've all seen them, okay? This is nothing specific here, it's all kind of general. But we're thinking this person is not the same as they were 6 weeks ago or 3 weeks ago or whatever, okay? So you're concerned, or people bring these concerns to you. Those of you who are in administration or program directors, whatever you do something. People they always say to me, isn't there any way, isn't there a test we can do? Try to find out who these vulnerable people are and maybe reach out to them. This has been looked at and studied. It really will. I say, look, let's use the AIDS model, and those of you who have been around in the early years of the AIDS epidemic, how we adopted universal precautions, that anybody coming to us could be HIV positive. And that's how we had to treat all new patients. Same way in the House of Medicine, okay? We have this persona, okay? Behind it, we can be very wobbly, but we've got a job to do, so we're doing our work. I want to show you now this very important 4-minute film. We put this together. This is a product of both the American Foundation for Suicide Prevention and the Mayo Clinic. There's an enormous amount packed into this, and it's called, Make the Difference, trying to reduce or prevent suicide in the training years, especially in residence. I've used this a lot. It's on YouTube. And those of you who are working in the wellness field, if you like this, you should begin using it because there's so many key messages there. So I've used it not just with trainees, but with physicians at many different career stages. Okay, I hope the volume will be okay on this. I'll say.
Medical training is challenging.
It can be frustrating,
Exhausting.
overwhelming, especially when things pile up on you.
My marriage is coming apart. I took out $183,000 in loans.
I made a mistake, a bad one.
Sometimes I feel like I'm in over my head. I just don't feel prepared.
Sometimes I think the real mistake was thinking I could be a doctor.
We all have our ups and downs, but if somebody starts acting really down,
Not able to sleep or sleeping too much.
Shutting her friends out, giving her stuff away.
If somebody just doesn't seem like himself,
not doing things he used to love.
Showing up late, not getting things done.
if somebody starts acting reckless or irritable,
Yelling at nurses, snapping at patients.
Drinking too much.
He might be feeling burned out, or depressed, or hopeless.
People who are smart and talented, they get overwhelmed just like anybody else.
And when they do, they may find it even harder to ask for help.
Medical students and residents have higher rates of depression and burnout than other adults.
they have a high risk of suicide too.
That's something we all need to understand, the risks, and how to look out for ourselves and each other.
And when it happens, people say, I had no idea. I thought he was just upset.
I thought she'd get over it.
I wish he'd come to me. I wish he'd said something.
I wish I'd said something. And now it's too late.
Suicide can be prevented. If someone you know is acting differently or really down,
Don't assume he'll get over it.
Say something. Say, "Are you okay? How can I help?"
The best way to prevent suicide is to show you care and get the person the help he needs. So don't be afraid to ask straight out.
Are you feeling so bad? You're thinking about taking your life?
People want someone to ask. They want someone to care. Faculty, peers, friends, anyone can ask.
Are you thinking about killing yourself?
And if she says yes, or maybe, or sometimes, here's what you don't say.
That's crazy.
One mistake isn't worth killing yourself over.
that's not going to solve anything.
What you do say is, I'm sorry you're feeling so bad. How can I help?
We'll get through this together. Let's get you some help.
Assume you're the only one who will reach out and get this person the help she needs.
None of us should be ashamed of getting help.
Getting help is the strong professional thing to do.
Let her know she has options, that there are people she can talk to.
Let her know she can always turn to you. Make sure she has the National Suicide Lifeline number.
And help her find someone she can talk to. Someone who knows how to help.
Ask the Dean for Student Affairs or the Program Director.
If you think she's about to hurt herself, don't leave her alone.
Take her to the emergency room. Call 911 if you have to.
We all get down. We all have our bad days. But sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Are you thinking about ending your life?
Don't wait until you're sure. Trust your gut.
It never hurts to ask. It never hurts to care.
It can make a big difference.
Any one of us can make a difference.
All the difference.
In someone's life.
So 2 years ago, we got rid of that long number, and it's now 988. Imagine trying to work with that number when you're feeling so desperate. It took a long time to get that reduced to 3 digits, trust me. But what's so important about this videotape, and I put this on this slide, the normalization of this, the importance of reaching out, our brothers and sisters keepers, so to speak, in the House of Medicine, it gives you language of what to say. Because a lot of people don't know what to say. It gives you language about what not to say, what to do next, and asking for help is a smart thing to do. You can see it's collaborative too. We'll get through this together, not here's what you need to do, here's a list of things, or here's some phone numbers, goodbye and good luck. Collaborative. We'll get through this together. Leadership roles, many of you in this audience, we know the importance of timing when we've got to deliver some potentially tough news, never on a Friday or before a holiday weekend, or if you're taking off on vacation or something like that where you're not accessible. These are the recipient of these things. Remember, this could be somebody who's quite isolated and alone, and if you don't know anything about their family or their support system, whether they have anyone, this can be a tough time. This is where chief residents, for instance, can be really so very, very important in our training programs. Okay? Brothers and sisters keeper, et cetera, et cetera. In this vigilance, okay, because there's been this hesitancy, we don't want to cross a boundary. It's really not our business. Don't know them that well. It's got to do with caring and vigilance and not being intrusive. And I can't begin to tell you the number of doctors I've looked after who have said to me, just as an aside, they wouldn't be alive today if it weren't for their colleagues reaching out to them when they were at their lowest, especially those with severe substance use disorders, especially opioids, cocaine, now things like ketamine as well, where they had really lost all insight and were really in a big, big, deep rabbit hole. and sometimes really aggressive as well in resisting care. And yet people persisted, made sure they got the care that they needed. But they do say this. So we do save lives, by this type of contact. This is an example of a national physician support line. I don't know if you have one in Colombia, but it's something that it's worth considering at times. It depends. This was started in basically the first weekend of the pandemic by a Philadelphia psychiatrist who started this with 2 other colleagues over a weekend. It was up and running by the first of the week, and it's still going. This is Dr. Mona Massoud. She has now over 800 psychiatrists across the nation who volunteer their time to man this hotline 7 days a week. It's about 12 hours a day. I know all kinds of physicians who are well situated. They're in big cities where they know people they could go to get care, but they're so ashamed or they're so worried about their privacy that they'll call this number. And you can make up a first name, that sort of thing, and get triage or get some immediate care. That's just an example of how these things work. This is the Dr. Lorna Breen Heroes Foundation. I just put these up there because I wanted you to just, highlight the work that they do. And this is also from the website of the National Physician Suicide Awareness Line. Just some 7 basic actions, just for you to have. In just a couple of final articles, we put this paper together during the pandemic, but to basically be aspirational and to continue when the pandemic eased off. So it's a systemic approach to a very complicated program. Dr. Christine Moutier, a colleague of mine, she's the chief medical officer of the American Foundation for Suicide Prevention. And Jennifer Feist is Dr. Lorna Breen's sister, Corey Feist, her husband, and Sid Zissik is a psychiatrist and former training director who's worked in the area of, he's now branched out into health professional suicide and doing a project on nurse suicide in the United States. And this is a much more recent paper, but very comprehensive, just a good paper to have. It's dense, there's a lot in it, but one of these things that you'll put aside and keep looking at from time to time. Our former Surgeon General, Dr. Murthy, talked about loneliness in our society. And what I liked about him is that he's been so self-disclosing about himself especially during the pandemic, and about burnout. So take-home quotes. Another tip of the hat to another Surgeon General, Dr. David Satcher, who was really the first Surgeon General to put suicide prevention on the map. That was in the early 2000s, just at the turn of the century. Reaching out, self-disclosure, brothers, sisters, keepers, and practice self-compassion. That's my book. And on the second paragraph, the stigma attached to mental illness in doctors, I wrote here, Dr. Myers argues that stigma must be fought with urgency and might. And I do mean that very strongly, that we all of us working in this field need to stand up, for ourselves and our colleagues. My final slide, which is the same as yesterday, I'm very grateful to Dr. Aviol and all of you and his team for having me here for this couple-of-day conference. And a salute to just so many of my colleagues and my students and patients of mine, et cetera, et cetera. Phone number, email, website. Thank you, everybody.
Thank you, Dr. Myers. Bueno, vamos a tener un espacio ahorita para un panel de preguntas, para conversar con los expertos. Tenemos otros invitados. Quiero introducirles a la doctora Andrea Plazas. La doctora Andrea Plazas es ginecóloga, es docente de acá de la universidad y es influencer en redes sociales, tiene un, ¿cómo lo defino? Como un canal que se llama Conversaciones Saludables, y le ha dado mucha relevancia a este tema de salud mental. Entonces, pues queremos invitarla también al panel. Queremos al doctor Ariel Alarcón también, que lo hemos invitado, y a alguno de los residentes, si quiere pasar al frente también. Y el doctor Oviedo.
Bueno, queremos conversar con ustedes, tenemos algunas preguntas también en el chat de YouTube y queremos también abrir la conversación. Entiendo que el día de ayer quedaron varias preguntas, inquietudes para el doctor Michael Myers y sea este el momento para poderlas hacer, y él está muy atento y feliz de poder responder y conversar con ustedes alrededor de este tema. Entonces, antes de nosotros abrir acá la conversación con este grupo de compañeros, queremos darle la palabra a ustedes, los asistentes, en las plataformas y aquí en el auditorio, para cualquier pregunta en este momento.
Al doctor Myers, si le traducen, que queda mejor. ¿Qué tipo de estrategias están haciendo las facultades de medicina, enfermería en Norteamérica alrededor de estudiantes de medicina y de residentes para la prevención de todo esto? ¿Qué tipo de estrategias están surgiendo nuevas que nos puedas comentar un poco alrededor de ello?
Okay, so now I use this, okay. Okay. Oh, okay. I'll put this. So now you all heard the question, okay, right? All right, okay. So let me start with primary prevention, because I think that this is really very important that we talk about the whole training atmosphere. When we make training in medicine doable and healthy and safe and maybe even fun at times, that's a very big step. Obviously, it's serious. Let's just use a 4-year model of 4 years of medical school. I mean, I've always felt that medical students, having been one myself, we've got enough on our plate, for 4 years becoming doctors at the end, that we don't need this other stuff like the hidden curriculum or bullying or stuff like that could really be a problem. That's in the workplace. So that gets us then into the mechanisms that have been put in place for behaviors, for instance, that when those of us here who are of a certain age trained, there was a lot of stuff that happened that we just either tried to ignore or suck it up or whatever, this sort of thing. When I look out and see women in medicine of a certain age, the stuff that you people put up with, for instance, I mean, I'm of that era where we had six women in our medical school class. They were all made to feel that they were taking the place of a man, so you better be good. Imagine that kind of a message, all right? But there's students even today, minority students, who feel that they're made to feel kind of lucky that they got in, perhaps by some type of privileged thing and I know this from black minority students, that they got in because of, mechanisms in the United States to take minorities, that kind of thing. All of that stuff has to go. We now have mechanisms in place where this stuff is reported. I talked about it yesterday, so that individuals can't get away with, teachers can't get away with behaving this way. And many of them are learning other ways of being good, proper teachers, that type of thing. Let me just jump now to services that are available. I think all medical schools have on-site counseling services for medical nursing students. At our, where I work at SUNY Downstate, we have a major counseling center for all of the health sciences students, because ours isn't just medical students. We've got PA students, nursing students, grad students, occupational therapy, excuse me, dental students, that sort of thing. It's free. It's on another part of the building. You still have to reassure students that there's a firewall between the dean's office, academic training, and whether they're getting counseling or not, that sort of thing. We've got a diverse staff of men and women, of also different ages and also different ethnicities for our diverse, medical nursing staff there. We also have much better psychiatry consultation services for those students who need that. Again, keeping things at arm's length. What we did, because I'm part of SUNY Downstate is part of a 3 medical school system that, because it was felt that some of our students felt that there could be a conflict of interest in that, for instance, if they're being treated by a psychiatrist who's also going to become one of their teachers in their clinical years, this could be a conflict of interest. And so what's been set up is virtual care by psychiatrists at one of our sister medical schools in another city. It's got its pros and cons, but it certainly has been helpful, that type of thing. We also have committees at our medical school as well that reach out to those students who have been off on medical leave and to make sure that they get the proper rehab for when they come back in a return to training thing, because I've looked after so many of these students that they feel kind of embarrassed at first because their class has moved on and they're going to be starting with the class behind them. But invariably, in fact, I've never seen an exception to this. That class that is receiving them always receives them with open arms. They're made to feel, look, you're one of us, we welcome you here, that sort of thing. And within a few short weeks, usually that student who's repeating not only feels very kind of welcome, if not even kind of loved, but they have a sense that, you know what, I'm glad I'm repeating, because there's a hell of a lot of stuff that I missed because I was so sick. And they can now see that this was an important part of their rehabilitation and their training. And so that kind of walks you through that. Then graduation. I'll just give one other example. We now have something specific to our LGBTQ plus students at Downstate, where we have what's called a lavender graduation, which is about 2 weeks before general grad, which is smaller, but it's held right on campus for those students who are LGBTQ plus. With speakers, their families come or their families don't come if they are still kind of in the closet about having a trans daughter or, a gay son or something like that. So that's something that's especially kind of helpful for them. They still go to the general grad, but it's something specific. And maybe I should just stop at that point. It's just sort of an example, just, for students.
Queremos invitar también a Isabela, estudiante del pregrado, quien manifestó interés también en participar y hablar de salud mental con nosotros. ¿Preguntas para el doctor Myers? Doctora Magda. Micrófono, por favor.
Gracias. Quería preguntar al doctor Myers qué experiencia tienen con búsqueda activa de esos estudiantes, si aplican tamizaje para identificarlos o es que están recibiendo a los estudiantes que llegan a buscar ayuda. Si hay alguna recomendación para hacer tamizaje. para identificar estudiantes en riesgo de suicidio?
Thank you for your question, and I'm glad you asked it. I want to just give you a little bit of history. About 25 years ago, I was giving a grand rounds in internal medicine about my work as a doctor's doctor, and I was paired with the woman registrar of our medical licensing board, and she was basically talking about really what are some of the reasons why doctors are reported to a medical licensing board. That was quite separate for what my talk was really about diagnosing and treating doctors. So I gave many disguised case examples of patients from my practice. And this was like 25 years ago, and this was internal medicine. And I'll never forget an older internist who was the first person to put up his hand. And he said, Dr. Myers, I'm just stunned and shocked about your practice. First of all, I didn't even know that there was such a need for something like this, that you have a full-time, or it's a half-time practice that's restricted to just looking after medical students and residents and practicing physicians. So I was nodding, and I thought that this is good, this is complimentary, and he said, this troubles me. You know, you work in medical, can you think of some screening tests that maybe we could do? Because I think there's a lot of people that need to be weeded out. So that they said, I'm sorry to kind of put you out of business, but it feels to me that some of these people need to be weeded out. So I've been around a long time. Even 25 years ago, I'd been around a long time. So I just smiled and I said, Doctor, I hope we never come up with that kind of a screening test. And let me tell you why. Some of the best physicians in this country, in this city, in this country, would not be doctors if they were eliminated because of a whole battery of psychological tests or something like that, that kind of thing. So with that, then, you know, I was trying to be respectful and honest, because in that audience were about a half dozen of my current patients. So they had just been told that they were outliers, and it's too bad we couldn't have screened them. In fact, he was sitting beside someone who was my patient. So I said to myself, I got a big education job to do here. We need to be able to explain that you can have a major psychiatric illness and be very high functioning, et cetera, et cetera. I want to get more specific to your question, though, which is so well intentioned, that if we can know which individuals might be at risk for suicide and provide some type of early intervention, will we save more lives? Ideally, yes. Identifying those people is very, very complicated. Well, first of all, it does touch sort of on human rights, for one thing. The other thing, though, is that suicide, deaths by suicide, actually, believe it or not, despite the whole subject of this conference and my talk today, it is considered still a rare event. But because it's such a tragic event, we spend a lot of time and effort talking about this and trying to prevent it, because we're talking about generally healthy, talented people who fall ill and get sick and then die by suicide. When it could be helpful would be those individuals, let me put this another way, what I would like more to see is that some way we can also have better screening in our across the board orientation, and even students who do come to the counseling service, because now with AI, we do know that there are much less threatening suicide screening instruments which will kind of highlight certain individuals, and then it gets progressive, and then it's looked at by a human being who then weighs in and then does a deeper dive on suicide risk assessment. Then you actually get an assessment by a human being, and especially somebody who's well trained in suicide risk assessment. But I have to tell you, it's such a delicate subject, though, that I have looked after so many medical students and doctors. When I look at my notes, the initial intake interview, nada. Nothing in the suicide realm at all. Clean, no previous, et cetera, et cetera. That's all got to do with self-protection, that sort of thing. That it's scary. First of all, for many people, it's embarrassing. They feel they're going to be judged. But secondly, am I going to be kicked out of medical school or residency or forced into hospital or something like that? That kind of thing. So that's why it's a really, really tricky business. What I try to do is to make sure when physicians, when they do come forward, that our risk assessments are done much more over time and carefully in a non-threatening way, but yet in a serious way. And we know this a lot from our emergency rooms, because there have been too many incidents of doctors being brought into emergency rooms and they're embarrassed, and the people who work in emergency rooms are embarrassed. They get cursory screening. The doctor-patient said, look, I'm okay. I had been drinking when I said I wanted to kill myself. And everybody's just panicked, like, I'm okay. There have been too many incidents where that person is dead within 2 hours or within a day of being in that same emergency room. So there's other ways that we've got to perfect this and do it carefully and make it safe to be able to talk with someone. And let me conclude with just one thing I want to tell you. There's a psychiatrist who's written a book called The Suicidal Patient. He's a Swiss psychiatrist named Conrad Michel. Or maybe it's Michel Conrad. But anyway, what his point was, he wrote this book because he studied a lot of suicidal individuals. Many of them have said, I had a perfect suicide screening. The person who did all of this was thorough. She didn't miss a beat. I got proper treatment. My life was saved, but yet I'm disappointed. And what they were disappointed was there was no human connection. They felt that this was robotic, that the individuals, yes, were trying to save their life, but they were also trying to save the reputation of this hospital, of this place, where they said things like, nobody seemed interested in me. Nobody seemed interested in my story. And really try to get at the bottom of the fact that I get this suicidal diathesis, And so he's written this book, which is really wonderful, and it's a wake-up call to all of us in psychiatry that we need to think about this a little bit differently. And he's also the survivor of his adult son's death by suicide. And so he really comes with decades of career experience, as well as, the human sense of losing his beloved son to suicide. So, thank you so much for your question.
Buenos días. Quería preguntar cómo podemos, de alguna manera, desde los semestres más tempranos de la carrera de medicina, fortalecer y fomentar la resiliencia y la salud mental para pues tener durante toda la posibilidad de mejorar la salud mental, ¿sí? Me gustaría saber qué opinión pues tienen al respecto.
Well, my opinion about that, I think, has been the bedrock of this day-and-a-half conference in so many ways. First of all, by putting this subject on the map, dedicating a whole sort of annual meeting to something like this, which is really very important. People coming together. And by the way, I think that we can all look on each of us as ambassadors, because we each know a lot of people who aren't here. And they're wondering what we're doing here. Or they're going to ask, what was that conference about that you went to last weekend? Or something like that. look at the people that we can educate, the people we can talk about, that we're talking about something that is so critical, but yet at one level is kind of still in its infancy. So your point is such a good one, that when in all medical schools, matriculate these bright, bushy-tailed newbies who are coming in, can't wait to study, to learn medicine, and yet make this a healthy, safe place. So what does that mean? That means some integration, certainly with maybe even prescribed stuff outside medical training, picnics, sporting events, volunteer things. Many of you, of course, will have this in your own lives. You'll have a network that you'll do this stuff with your families, with your friends. That's good. That's very good, and preserve that. But sometimes it's also good to do it with your colleagues, that you kind of get to know them as people, in addition to knowing them as fellow students. Obviously, lots of emphasis, of course, on the things that we've been hearing about: proper nutrition, exercise, mindfulness meditation, or these other cognitive strategies, all of these kinds of preventive things. So it feels as if you're also got some say in this, that you can, still strive for balance. And then maybe at the end of the day, when you evaluate your first year, your second year, or whatever, that you conclude, yeah, this was a tough year. It was a busy year, but yet not only did I learn a lot about becoming a physician, but I learned a lot about myself and my own sort of strength. I think and I'm now using the word resilient in a good way. I've kind of learned that, I'm becoming increasingly resilient in a good way, not in denial. I don't bury my head in the sand. And I had a bit of a rocky road this year, but I talked to peers at school because I wasn't sure whether or not I should go talk with someone. It was enough just to talk with my peers. Others may say, I talked with my peers, but then that helped me to actually go talk to a therapist. And that's been wonderful. In fact, I've decided to talk openly about that. I want to normalize that for my classmates who are scared stiff to talk with someone. And I think we might even have someone here today.
Thank you.
Doctora.
Vamos a hacer una pregunta, esta última pregunta, y pasamos para unas preguntas del panel.
Gracias.
Bueno, para que se presenten también.
Como médicos nos preocupamos por el tratamiento. Quiero saber si tiene alguna experiencia en el manejo de estas patologías que afectan la salud mental con medicaciones o drogas ancestrales. No desde, como los psicodélicos, no desde lo químico, sino desde las drogas naturales como psilocibina, mescalina. En algo ayudan, que se puede hacer microdosis, macrodosis, cosas que se hablan. Gracias, doctor Mayer.
Yes and no. Any first-hand experience? Nada, nothing. Is this a hot topic? You bet it is. And I know that there's a lot of experimentation going on because I sometimes have seen the fallout to this in some doctors who I assess who have gotten into trouble at work because they've been experimenting on their own, or they've gone to what I would call maybe a backdoor clinic that apparently is offering both therapy as well as the psychedelic drug experience, and it's not a good place. These are not well-trained, well-regulated centers. They've had a bad experience. It's affected them at work. They're in trouble there, and then now I'm assessing them to make sure that they get actually a proper diagnosis and proper care. At one level, they've tried to head off the kind of conventional care. They said, I know there's conventional treatment for major depressive disorder, but I thought I would try one of these psychedelics first or something, and so far it ain't working so well. But there's a lot of study of these because there is some very positive study of these as well. But there's also some not so positive stuff. So it's really in its infancy. And I'll just tell you one thing, as the chair of the scientific program of the American Psychiatric Association, we got a number of submissions last year for our meeting in Los Angeles, and we got a lot of submissions this year as well for psychiatrists coming to the APA meeting this next year in 2026 in San Francisco. There's going to be a lot on the program on this subject.
Quisiera darle la palabra un momento a las personas acá presentes para que se presenten brevemente y expresen alguna idea alrededor de su interés en la salud mental de los que cuidan.
Muchas gracias, doctor. Pues para los que no me conocen, mi nombre es Alejandro Ardila. Yo soy el actual jefe de residentes de Psiquiatría General de acá de la universidad. Realmente como me alegra mucho estar acá compartiendo, no solamente con profesores míos del pregrado, realmente me alegra ver muchos profesores también del Rosario, sino pues también de estar acompañados de estudiantes de medicina. Ahorita pues tengo el honor de que estudiantes que fueron nuestros ahorita pues son colegas, son compañeros, y algo que a mí me ha dado como la experiencia de estar acá, y que en muchos puntos antes de llegar a psiquiatría, en entrevistas, me plantearon muchas preguntas muy interesantes. A propósito como este tema del suicidio, recuerdo en algún punto de este proyecto para entrar a psiquiatría, un director de una institución me preguntó: ¿usted admitiría a psiquiatría una persona que tiene o que reporta que ha tenido un intento suicida? Estoy seguro que la pregunta que me hizo en ese momento no era una cosa en blanco o negro, sí o no. Una serie de matices, una serie de historias detrás, porque sé de los compañeros de acá, de los compañeros de otros programas, que todos venimos de un trasfondo en donde yo creo que personalmente muchos de nosotros somos sanadores heridos, que además admitir nuestra propia vulnerabilidad en muchas ocasiones nos da miedo. Nos da miedo por que esto nos pueda cerrar caminos a futuro, que si lo menciono en mi entrevista a medicina no voy a poder ser médico, que si lo menciono en mi entrevista para ser cirujano me van a descartar. Por el contrario, y pues a propósito de todo lo que hemos visto en este simposio, creo que tiene mucho valor también poder ver y admitir nuestras vulnerabilidades individuales, ver nuestros fuertes, ver qué tipo de cosas nos cuestan, trabajar como comunidad, no solamente de médicos, sino de personas. Y pues en parte, pues creo que por eso estoy acá. Extendí un poco, qué pena.
Gracias, buenos días. Mi nombre es Ariel Alarcón Prada, también soy un sanador herido y dentro de un par de semanas va a salir un libro publicado sobre la experiencia que yo tuve en Armero, que compartí aquí con varios de mis amigos, con Carlos, y que estamos por esa época por acá, luego nos encontramos. Y en el último capítulo del libro, también soy escritor y bueno, hago talleres de mindfulness mucho. Hacemos un trabajo, a veces cuando trabajamos en proyecto de vida y en sentido de la vida, pensando en temas de resiliencia, hacemos un pequeño ejercicio que es el del epitafio, que es cuando usted se muera, ¿Qué lectura quiere que escribamos en la lápida de su tumba? ¿Cómo quiere ser recordado? ¿Cómo cree que puede llegar a trascender? Y yo ahí escribí uno muy serio y muy largo, no cabría. En la lápida no cabría, bueno, que ser recordado como el psiquiatra que se preocupó por la salud mental de sus colegas y bla, bla, bla. Pero después se me ocurrió así medio bromísticamente poner el psiquiatra de las medias locas. Por eso es que ando así, y ya Natalia nombró la campaña de las medias locas. Soy uno de los abanderados de esa campaña de el bienestar emocional de los profesionales de la salud, a partir de una campaña, no sé si en Norteamérica la siguen también. Ok. Y porque estoy convencido de la importancia de la prevención en general en salud mental y de la construcción de bienestar. Pensando en la pregunta de resiliencia, yo creo que eso tiene que ser parte del currículum de todas las facultades, y trabajar con mucha conciencia en torno al bienestar, porque vamos a estar sometidos a situaciones estresantes y que nos pueden poner en graves riesgos, como hemos visto hoy. Entonces, teniéndolo en cuenta, pues metámoslo dentro de la conversación y trabajémoslo muy conscientemente. La construcción del bienestar genera necesariamente resiliencia. Y pues he oído muchas presentaciones, he estado muy feliz este par de días recordando, pero viendo cómo muchos elementos de los que vengo trabajando hace algunos años son cada vez más reconocidos, ¿no? La importancia de mindfulness, la importancia de la autocompasión, la importancia del cuidado entre pares, ¿no? Que el doctor Meyers hizo tanto énfasis en su última charla, me parece que es trascendental. Cuidarme a mí y cuidar a quien tengo a mi lado, preocuparme por él. Bueno, es como mi presentación.
Hola, buenos días a todos. Yo soy Andrea Plazas, soy ginecóloga. Y creo que eso, que yo diga que soy ginecóloga y estoy en este simposio, realmente me hace demasiado feliz que me hayan invitado. Me siento honrada de estar acá compartiendo con ustedes y con dos personas que son inspiración, que los sigo, que mejor dicho, ustedes han sido parte de muchas cosas que me han impulsado a seguir en este camino. Tengo un podcast en donde estoy, súper enfocada en hablar sobre salud, bienestar, todo lo que nos hace bien, esto es salud física, salud mental, salud emocional, todo lo que sirva para vivir mejor, ahí va, en este canal. Siento que estos espacios, ya creo que resumiendo y volviendo a retomar todo lo que han dicho muchas personas, son fundamentales para que se hable del tema y que muchos podamos ser abanderados de esto, de que seamos embajadores realmente de la resiliencia, del bienestar. Y esto, digamos que, llegando a tu pregunta, la que hiciste previamente, creo que todos somos actores de eso, desde todos los lugares donde estamos, digamos que donde tenemos impacto en las demás personas. He sentido, gratamente el apoyo tanto de la institución, trabajo en el Hospital San Ignacio, como en la Universidad Javeriana, por parte de la facultad, en generar espacios donde esto pueda reforzarse y pueda crecer. Y no solo son ideas mías que a mí me surgen, yo he grabado episodios del podcast con estudiantes, con colegas, estos que están allá atrás, que me han acolitado todas las locuras, pero con estudiantes de pregrado y posgrado que pueden compartir su experiencia, compartir sus dudas, sus inquietudes. Y mira que fue muy lindo que recientemente, cuando uno como que lo ven como un referente de salud, de bienestar, de todo este movimiento, lo buscan a uno para, hey, queremos que llevar esto, tenemos estas ideas. Y justamente hace poquito surgió una idea de una estudiante de pregrado, quinto semestre, en generar un grupo de interés en donde todo el mundo puede participar de la comunidad javeriana para generar esto que es espacios, comunidad, tener todo este apoyo tanto del hospital como de la facultad es súper importante, tanto para nosotros que somos quienes estamos acompañándolos en su proceso de formación, como de ustedes que también tienen la fuerza y el fuego para generar ideas e iniciativas súper interesantes, y creo que todos tenemos que trabajar en conjunto por eso. Entonces, así que me encanta ser parte de la conversación, porque creo que todos tenemos algo que aportar y somos tanto como cuidadores como podemos llegar a ser alguien que necesita también ayuda.
Bueno, yo soy Isabela Medina, soy estudiante de sexto semestre. Digamos que no tengo la misma experiencia acá, hablo como desde el gusto y desde que me llama mucho la atención desde muy chiquita la psiquiatría, pero también hablo mucho desde la experiencia, digamos que también sobre la pregunta que hacían sobre qué se puede hacer desde los semestres más pequeños. Digamos que para mí ha sido toda una travesía, porque he pasado por diferentes situaciones a lo largo de la carrera y fue muy difícil, digamos, inicialmente ese poder buscar ayuda por eso mismo del miedo de más adelante qué pasará con mi carrera o con mi futuro universitario. Digamos, evidentemente me encantaría ser psiquiatra, amo esta universidad, pero también decía como bueno, y o sea, el día de mañana no me van a recibir porque pues, o sea, yo también estoy enferma, ¿no? Entonces digamos que entrar como en ese choque fue algo muy difícil, y eventualmente la ayuda de alguna manera u otra llega, y también digamos que ese espacio se da mucho generando este tipo de espacios de conversación. Entonces creo que ha sido muy bonito como poder transitar desde el lado de paciente, desde el lado de estudiante, y nada, creo que es un camino muy largo. Creo que los espacios siempre están, pero no siempre los buscamos de manera adecuada, y también siento que igual se pueden abrir muchísimos más espacios. Digamos que algo que me ha parecido muy bonito es encontrarme con compañeros. Bueno, yo hablo muy abiertamente de mi experiencia, sobre todo en mi semestre y con los compañeros que conozco, y eso ha generado un espacio muy bonito porque he recibido como he encontrado mucha cercanía con personas que han pasado por situaciones similares y que se han acercado a mí, que no les puedo ayudar de a muchos, solo les puedo decir como mi experiencia y lo que yo hice para buscar ayuda, pero de todas maneras siento que he abierto como ese espacio entre compañeros de dar ese primer paso, de decir yo también necesito ayuda, con quién puedo conectar, ayúdame a llegar a algún lado, y creo que eso es como fundamental, ¿no? O sea, digamos, hablar como desde los pares es muchísimo más fácil que saltar directamente a un profesional que no conozco. Entonces creo que eso sería como lo más bonito de esto.
Muchas gracias. Hago acá una interfase para algunas preguntas que nos están llegando. La doctora Paula Murcia, directora de la unidad de anestesiología de la clínica del Country, tiene una pregunta para el doctor Michael Myers. Dice: hemos hablado de residentes, estudiantes, y cómo desde la transformación en el currículo y docencia ayudamos a los nuestros. Pero cuando somos médicos que no estamos en formación en cargos de liderazgo, ¿qué podemos hacer para protegernos y proteger a nuestros equipos? ¿Cómo instaurar una cultura de cuidar al que cuida y especialmente a los líderes, quienes tienen más riesgos psicosociales?
So the question is for obviously people beyond training, but who are not in leadership, and what can they do to maybe protect?
Especialmente en líderes, para líderes, jefes, directores, que están también orientados a querer cuidar, pero que reconocen sus riesgos en estas instancias de liderazgo.
I'm not sure if I'm following, meaning that if leadership finds out that's a problem?
Como los riesgos del liderazgo.
I'm still not following though, that is to help medical leaders like you people to...
Yes.
Yeah.
It's about what can we do about our leaderships in terms of helping others and also prevent our own burnout.
Okay, all right. So one thing I'm wondering, do you have in this country then, actually, what I'm wondering is whether or not you have a cohort in Colombia, we'll say Latin America, where you get together as say program directors every year, like an annual meeting, or where you as a chair have a meeting of chairs of psychiatry, or the deans get together in those meetings. So what my question is, in those meetings, is any of the programming, does it ever have anything to do with wellness and health for you? You're kind of nodding and you're going because you bear an enormous amount of responsibility, and as there's that old saying, it's lonely at the top, because who do you go to? And now you may be fortunate enough to have a long-standing therapist or something like that. That can be helpful. But among colleagues, though, I know in America that there certainly are at the annual meetings. The one I'm most familiar with is called ADBIRT. That's the annual meeting of training directors in psychiatry that meets every year. And there's always a lot of workshops built in for us. You know, things that we can do and learn both at the meeting and where do we go beyond this. And one of that is sort of an informal network of colleagues at your level that you can speak to largely about two things. One would be where you're dealing, for instance, with a very complicated sort of work situation, perhaps with a trainee, that type of thing that has gotten very, very big. And you kind of want the experience maybe of another program. Have they ever dealt with something like this? What can we learn from that? So that's more in consultation. But also, though, just in terms of one's own mental health, it takes a lot of trust. But that's where we all take risks at times, I think, you know, with somebody who we hope is trustworthy, that we can say, look, I'm in trouble and I'm the director of this program, or I'm the chair of this. Do you have any suggestions of where perhaps I could go for help, or somebody I could talk to, or something like that? And that's a question that's been posed to me a lot as known as a doctor's doctor. And I'm usually able to find colleagues, for instance, in other centers, you know, that can provide that type of care. Now that's on a sort of more case-by-case basis. But I think, though, the same principles apply as we're talking about somebody who's starting medical school and having to, at that very early stage, try to lead an integrated life. You also know at your level that you have to do that too. That you have to say, look at, you know, enough is enough. This is all I can take on at this time. I've either got to delegate or conclude, you know, my term at the end. And I want to give an example, and that's Dr. Carrie Cunningham that you showed on your slide for, you know, when Dr. Over mentioned her as along with Michael Weinstein, I would urge all of you to both look at their stories online. Dr. Carrie Cunningham, which is and I know both of these people, the more recent one, her story is just unbelievable, and it's very, very powerful because she's a surgeon. And I was thinking earlier when you said if people are maybe going to say, well, I don't know, you've had a suicide attempt in the past, you know, we don't want you or something like that. First thing I would do, first of all, let me know, and then I'll let Carrie Cunningham know. And then she'll do something about this as a former chair of academics. So she's the chair of the Association of Academic Surgeons, So we have the equivalent. We have the American College of Psychiatrists, for instance, in the United States. I know that has a well-being arm to it as well. And those are some of the most, preeminent sort of psychiatrists. So all I'm saying is that it's very important that you also have both access to help, but also, I guess, maybe enough humility to also ask for help, or if you don't recognize it, if somebody comes to you and says, let's go for a walk, I want to talk to you about something, and those are hard conversations to have, but all of us, though, and I've had to do that with people who are well above me in terms of rank and hierarchy, where I've had to take them for a walk. And usually it works out okay, but not always. But otherwise, that individual is completely isolated. And when and if we hear about that kind of a tragedy, that just breaks our hearts. We think that this is sad, that's probably somebody who had no one to turn to. So, as Dr. David Satcher said, suicide prevention is everyone's business. That's all of us. Every one of us here in this room.
Bueno, si quieren una conversación.
Gracias. Sí, pensando en la pregunta de la colega de la clínica del country, yo creo que los líderes en medicina tienen un rol doble o triplemente estresante mayor que el de cualquier otro. Ya la tenemos complicado los soldados rasos, los médicos y enfermeras comunes y corrientes de todos lados. Pero cuando uno le toca dirigir un departamento o dirigir un servicio o dirigir un grupo de gente, se aumenta enormemente la carga de estrés y se aumenta enormemente también la responsabilidad por la apariencia del bienestar. En cuanto al tema del estigma, que el doctor Meyers tocaba hace un rato, y a mí me parece que la solución está en el liderazgo compasivo, que incluye y tiene necesariamente que incluir la vulnerabilidad del propio líder y hablar sobre las vulnerabilidades. Todo el tiempo en distintas charlas hemos hablado de eso, ¿no? Tú también lo nombrabas. La importancia de reconocer la vulnerabilidad y ponerla sobre el tapete, que la vulnerabilidad no sea parte del currículum oculto. Es decir, yo como líder también tengo mis vulnerabilidades y tengo mi derecho a expresarlas y decir, venga, estoy con burnout, estoy con estrés, estoy con depresión, y el grupo tiene la obligación, eso es algo que tiene que haberse acordado y generado previamente dentro de la cultura organizacional. Ven, te vamos a apoyar, eres uno más de los nuestros que está pasando por un momento de dificultad y por supuesto que te vamos a apoyar para sacar adelante tu dificultad. Todos vamos a aprender de esa circunstancia, porque hoy me toca a mí y mañana te puede tocar a ti. Y si reconocemos la vulnerabilidad y no la volvemos parte del currículum oculto, sino todo lo contrario, una fuente de fortaleza, entonces se genera una corriente muy importante de crecimiento interior para cada persona y para el equipo completo. Me parece que es uno de los como approaches que podemos tener en esa situación. No sé si tú quieres decir algo desde tu rol de líder.
También creo que pues todos hemos crecido en un entorno donde hemos reforzado mucho como el desarrollo de habilidades duras, en donde somos impecables en lo que hacemos científicamente, sabemos un montón, nos va muy bien con los pacientes. Hay que reforzar que el líder también esté interesado en que su equipo desarrolle sus habilidades blandas, esté pendiente de esto, tenga digamos también ese espacio que tal vez el doctor Santa Cruz lo dijo ayer en su primera charla, y fue el equipo tiene que ser una cosa como que se compenetren todos, en tanto que todos están protegiendo a todos. Siento que es también parte de formar equipo, es formar una especie de familia en donde todos estamos preocupados por todo lo que nos está pasando a todos.
Bueno, Bueno, este panel también nos ha permitido visibilizar y hablar acerca del suicidio abiertamente. Yo quisiera preguntarles ¿cómo es el papel de visibilizar esto en redes sociales? O sea, ¿cómo es la experiencia que ustedes han tenido? Que sé que hay 2 personas que trabajan en esto, como de compartir las experiencias ahora que se hacen, no solo desde lo personal, sino que también se vuelve todo más viral, ¿no? ¿Cómo es esa experiencia? Y los estudiantes también.
Yo quiero justamente compartirles mi experiencia con lo que hicimos para el mes, para el 10 de septiembre, que fue pues, el Día de la Prevención del Suicidio. Yo quise traer un testimonio de uno de los médicos recién graduados de la facultad, que está muy interesado él en sus proyectos personales en hablar y visibilizar el suicidio. Yo siento que las redes sociales ahorita tienen un papel bien importante de informar, educar e inspirar, pero las mismas redes sociales se han encargado de que sea un poco complicado porque a veces se quiere sacar como ese partido para viralizarse hablando de temas delicados, y por eso mismo las redes mismas se encargan como de tal vez bloquear cierto tipo de contenido. Hablar de suicidio en redes sociales es súper complicado porque o lo tratas seriamente con responsabilidad o te vuelves alguien que está hablando, digamos, desde un lugar muy complicado y se vuelve viral por las razones que no son las adecuadas. Entonces siento que también ahorita que yo soy como pues que me he metido tanto en conocer, aprender y hacerlo de una forma como muy informada y muy responsable, siento que las redes son importantísimas para concientizar, para llegar a ese momento como de que la gente tal vez no se haya dado cuenta y como que ping, se le prende el bombillo de ve, esto existe, toca hablar de esto, tal vez todos somos agentes del cambio, y creo que las redes también tenemos que aprender que eso tiene, o sea, ciencia y responsabilidad a cargo, porque uno tiene que ser un líder responsable con lo que se difunde, pero yo sí quiero decir que la experiencia ha sido muy positiva cuando uno lo hace desde un lugar informado, coherente y responsable, porque la gente conecta un montón, sobre todo con los testimonios. La gente se engancha, empieza a preguntar, escribe, pregunta y es capaz de mostrar esa vulnerabilidad tal vez de que no han sido capaces de mostrar en otros espacios, y dicen yo también he estado ahí, y creo que ese es el poder que tenemos que darle de una forma como muy responsable.
Yes, I'm going to, thank you, I really enjoyed what you had to say. My experience of this is vicarious, but it's got to do with the fact that I have interviewed scores of doctors who are very active on social media, and I would say that largely they have found the experience positive, but they've also admitted that when you do something like that, you are taking a risk. And those who have had already a good support system in place have found that very, very helpful. First of all, they said, because of the trolls, they said, but that's almost to be expected, so they're not so much concerned about that. But somebody who is known as the wounded healer in the UK, who's a psychiatrist, who I gave an award to at the last meeting of the American Psychiatric Association, the Public Service Award, he's very active in both X as well as in LinkedIn. The negative aspects that he's experienced has been from fellow psychiatrists who have really felt that he's crossed a line in being too transparent. And he's not even transparent sort of really about the specifics of his own either diagnosis or treatment. It had more to do with the fact that he is very vociferous in human rights. And it's very basic. He's very committed to human rights. And so, but he's okay with this. He carries on. He said that this is the message. The other person who you alluded to from Crazy Socks for Dogs is Dr. Jeffrey Toogood in Melbourne, Australia. And by the way, those of you, and I'm so glad to see that your socks and the referral to him, because his initiative has really been wonderful, Dr. Toogood, because the Crazy Socks story is really interesting in itself. But he got into this because of something. He's a cardiologist, by the way, who suffered depression. But he said he got into this because he was told by his colleagues, say, you've just got to become more resilient. And that really bothered him because he felt, look at, I'm trying to be as resilient as I can be or whatever, but I'm ill right now or whatever. I'm getting treatment, that kind of thing. But he felt blamed or that sort of thing. So he's somebody who's really done a deep dive on the term resilient. But Jeff Toogood is he's also a channel swimmer, as you know, this sort of thing. But he's another example. Carrie Cunningham, in addition to what I said, she spent, because the talk that she gave that's become so public was her retirement speech at the end of her year as the president of the American Association of Academic Surgeons. And so she was very aware, and again, we're talking leadership here, that she spent part of her leadership year in rehab. And felt that, she wasn't able to do her year as the way that she had expected to do it. But she was and this was in front of 1,000 colleagues, and she got a standing ovation. So that tells you something about the support out there among our colleagues for this type of thing. Not everybody's going to be able to speak openly. Not everybody's going to be able to go on social media. But those who do and have our support, they know that they really have the backs of 99% of if not higher, of their colleagues. So I think it's very comforting knowing that, actually. So.
Yo quería también, mi experiencia con esto también es un poco vicaria. No soy la persona más activa en redes sociales, pero sí conozco de colegas, compañeros, estudiantes también que tienen pues toda esta experiencia comunicando desde lo psicoeducativo, que creo que es lo que usualmente se nos viene a la cabeza. Tengo una cápsula hablando del trastorno límite de personalidad. Tengo una cápsula hablando de ciertos tipos de psicofármacos, mitos y verdades. Pero una cosa a propósito del trabajo que tú has hecho es que creo que el valor del testimonio, y con los testimonios que también nos trae el Dr. Myers, es las redes sociales nos permiten, además de consumir muchos tipos de contenido, conocer historias de vida. Y si no lo hacemos nosotros, que estamos acá metidos, realmente la figura que a veces tendemos a proyectar es como todos estamos perfectos. Tal vez por eso la gente no conecta tanto. Y uno ve muchas veces, con buena, mala intención, pues muchas personas que son humanas en redes, son transparentes. Y eso incentiva a las personas a conectar. Y si uno se pone a ver los comentarios y probablemente si verá los mensajes privados de estas personas que están siendo activas en redes, siendo transparentes acerca de esta cuestión de la vulnerabilidad, probablemente uno encontraría una diversidad de personas que el mero hecho de ver que alguien más tiene una experiencia compartida puede ser el primer escalón para poder aceptar ayuda, poder reconocer que hay un problema. Y para los colegas que están como en todo este ámbito como en la psiquiatría, pero pues también para el resto de nosotros, pues la invitación es a eso. Yo creo que ninguno de nosotros está vacunado en contra de, y por el contrario, mi experiencia al menos, digamos, ha sido un poco con los grupos estudiantiles, con los grupos de estudiantes, que muchas veces esto abre la puerta para una serie de experiencias, para una serie de oportunidades que de pronto si no estuviesen ahí, si la doctora no tuviera su podcast, ¿cuántas personas de pronto no se hubieran animado a buscar ayuda y a hablar de estas vulnerabilidades?
Isabel, ¿algunas ideas sobre redes sociales y salud mental desde tu perspectiva?
Bueno, pues yo soy más consumidora que promotora en redes sociales, pero creo que, digamos, es un tema que también considero bastante peligroso, voy a decir, porque creo que, bueno, estando del otro lado de la pantalla, el hecho de seguir como tags o líneas de depresión, de suicidio, te conduce tanto a información como educativa como a información muy dañina. Entonces, digamos que me ha salido todo tipo de contenido y también es ver cómo existen redes de apoyo incluso en estos espacios, como cuando una persona sube videos, digamos, que de alguna manera u otra está pidiendo ayuda, como también hay apartados que te dirigen automáticamente a las líneas de apoyo de tu respectivo país. Entonces, digamos que esto también, como estos espacios en los que se intenta implementar ayuda directa en redes y no solo, pues, digamos, para no volverme repetitiva eso de las experiencias, que me parece increíble y que lo consumo un montón, también está eso como de dar las líneas de apoyo directamente, porque muchas veces hay personas que están ya en medio de la desesperación, digamos, consumiendo este contenido, no sé, en situaciones ya que están poniendo en riesgo su vida, y tener ahí mismo el acceso a líneas, pues me parece maravilloso, y creo que también es importante eso, como dar esa visibilidad a que hay muchos recursos que podrían ser incluso, pues, digamos, anónimos, como hablábamos, a los que se puede acceder como en esos momentos.
Muchas gracias, Isabela. Vi alguna mano levantada para más preguntas para el doctor Myers, para cualquiera de los asistentes. El doctor Daniel.
Bueno, muchas gracias a todas y a todos por la información que han compartido. Yo sé que este tema de la prevención es muy importante y hemos hablado pues casi que las 2 jornadas del tema, pero mi pregunta va más relacionada con qué pasa después, ¿no? ¿Qué pasa después de que un colega, un estudiante, un residente, un médico, un psiquiatra se suicida? Digamos, ¿qué se puede hacer como equipos de salud mental o como profesionales después de que esto pasa?
A lot, and thanks for bringing that up. When it's somebody in training, I'll just start from the standpoint that we do have toolkits, for instance, that are available, and they're published by the American Foundation for Suicide Prevention. We have a number of them, but there's one that is when a medical student dies by suicide, another one when a resident dies by suicide. And so these are available to all institutions, and they're now translated into a number of languages as well. But they're basically, though, a sort of step-by-step beginning at the moment of learning of this tragedy, what you do in the next hour, the next 2 hours, the next day, and the circle of impact, which starts, of course, with the family. And that's something right there. A family is in shock. Some of them will still, though, be okay about this, the need for support in a concentric circle of the peers and the stuff like that, especially if the suicide has been quite public, because sometimes they're not, of course, and then that becomes somewhat protected, and especially for the family. But even when the family are close ranks which is, a not uncommon reaction to something so horrible. There's still many, many things that can be done at an institutional level. And that, of course, is through the dean's office, the president, and it's in the various departments, and it's meeting with key players. It's offering support at so many different levels. It's relieving people of duties of care, taking care of themselves, but yet still sort of running an institution. It's highly detailed and has to be kind of, fine-tuned to the, to the situation. But having said that, though, that's just, in a sense, a template. What actually follows is attitude, that this is something that has affected all of us in many different ways. And one thing you have to be prepared for is the humanistic reaction that ranges all the way from what would be sort of a conventional kind of grief response with a whole panoply of emotions, which is all normal, to individuals who really do go into complete denial that this has really not occurred and do not want to have anything to do with this at all, that sort of thing. And that group has to be understood too, because that means that this is even more profound. It's probably, touching on something in their own, personal life or something like that. And I've been in situations where, for instance, I've been notified, I'm thinking, and I'm disguising this, of a resident's death in another country in a setting where they wanted me to come and give a rounds on this, not immediately because they're dealing with it with critical incident debriefing, but to come in about a month. But I remember very carefully, though, saying yes, and they said, but there's a catch. And I said, well, what's that? Well, you're not allowed to talk about suicide, even though they had told me that the death was by suicide. And so I said, okay, I'm going to have to, just kind of leave that with me. And what I did over the next several hours was speak with my colleagues. The advice I got ranged all the way from, then don't do it. I mean, how can you do it? To, well, of course, you do it. You show up, that sort of thing. And then all kinds of stuff in the middle, stuff like that. Other people saying, so what if you can't talk? But that's just what the family says. You have an obligation to the university, to the medical school, not just the family, that type of thing. So the family have forfeited their rights. I mean, people say some wild stuff, I got to tell you, after something like this. Anyway, in this case, I did do it, of course, this sort of thing. And I used an euphemism. I said, when a resident dies suddenly. And sort of started from the generic and gave reasons why sometimes residents die suddenly and how that impacts on the whole institution and colleagues and that sort of thing. And then opened it up for questions. Of course, you can read between the lines. Every question was about suicide. But this had to do with the respect of the family, who were both physicians and both on faculty of this particular training site. And so even though they were sort of accepting of the fact that their beloved son had died by suicide, they just didn't want this to turn into some sort of a public sort of thing. And so they ended up actually being grateful that they were able to find somebody who would schlep all the way there and do this and meet with this sort of grieving community, but not really kind of turn it into a circus, which they were afraid of, because that happens sometimes, where people say some pretty ugly stuff sometimes. And so that's why you've got to do sort of damage control too. So this is why, for instance, and I'll just pick up on language that you used, which is used a lot, and that's the verb commit when somebody commits suicide. There's been a movement now in the United States and beyond that we get rid of the verb commit from death by suicide. And where that stems from are from loved ones of not just doctors, of individuals who have taken their lives. And I actually witnessed this at a suicidology conference I was at, where a woman told her story of losing her daughter to suicide, and then there was a group afterwards who came to talk with her, and they were mostly family members who as well had lost someone to suicide and wanted to thank her for her bravery in telling the story. But there was this individual who I didn't know who identified himself as a psychiatrist and said to her, what you didn't disclose was, when did your daughter commit suicide? The woman said to this psychiatrist, my daughter didn't commit suicide. She killed herself. She didn't commit a sin. She didn't commit a crime. My daughter killed herself. Because, see, suicide is rooted in crime, in sin. And that's what this grieving mother was protecting her daughter from. And so even when I trained in the late 60s and early 70s, this was in British Columbia in Canada, suicide was still a crime. Suicide attempts were a crime. I even had attendings with certain patients who had attempted suicide. They said one way of getting rid of some of these patients is to just say, are you aware you've committed a crime by attempting suicide? I'm not going to admit you, would you like to leave? I mean, that person was never a role model of mine, but that was one way that they were cleaning out the emergency room, that sort of thing, in the morning after. But in an earlier book that I did, my co-author, Carla Fine, and I, who's a survivor of suicide law, she and I interviewed members of the clergy. We interviewed priests, we interviewed ministers, we interviewed rabbis, imams, and that to get a contemporary understanding of where they sit in their faith with suicide. And none of them, and the most progressive, had still, would say something negative of a congregant that, I'm sorry, that your daughter has, committed a crime, by killing herself, that sort of thing. They were all embracing, a mental health model that leads to death by suicide. So that's why, for instance, there's been this movement to try to just get it. It's the same thing as successful, because you'll sometimes hear in emergency rooms that after 3 unsuccessful suicide attempts, this patient was successful and died of her 4th suicide attempt. Families don't want to hear the word successful attached to death by suicide, because we tend to think of success as something positive. So this is it's a question of semantics of language, that we can be sensitive to. But anyway, just to get back to this, and just I'll finish up. The main thing, though, is that this does become something, though, that is indeed talked about in a medical training center. However, having said all of that, though, there are still institutions, though, who sweep stuff like this under the rug. And I'll give an example, which I'll disguise it a little bit, but I don't have to disguise it a lot, where I was invited to give a grand rounds at a center in the United States where a well-known physician had taken his life. They wanted me to come. It was set up for about 6 weeks. It was closer. It was 3 days before they canceled me, and with no explanation. And so I managed to, I was canceled by an administrative secretary, and I said, oh my God, I said, yes, sorry, any expenses, if you've already, bought your plane, we'll reimburse you, of course, that sort of thing. Anyway, I did some digging, and I was finally able to find out why I was canceled. The reason why I was canceled was because somehow this got out into the general public that Dr. Myers, especially, was going to be coming to this medical center, and they wanted to also maybe have a town forum or something. If they could contact me, would I be willing, to meet with, the community? Well, when the institution heard that, they felt exposed. And what this individual said to me, who canceled me, said, what made me so angry, Dr. Myers, was that when he killed himself, we had already fired him So he wasn't here, he was at another institution, but we got caught in the crossfire that they associated his suicide death with our institution. So that's why we canceled you. And it was just his language. We had already fired him, meaning we had already gotten rid of him. Then he goes and kills himself at some other institution, and we get caught in the crossfire. So that was 7 years ago. So this is still a difficult subject for some settings that let's not talk about this. It's not good for business.
Vi otras manos levantadas por acá, el doctor Germán Casas.
Una pregunta para el doctor Myers es, ¿qué opina usted de los grupos de soporte peer-to-peer support? ¿Cómo se decía en español? Como soporte de pares. Lo digo rápidamente, yo he trabajado mucho tiempo con Médicos Sin Fronteras en varias partes, aquí y en otras partes del mundo, y dirigí un tiempo los equipos de salud mental. Ariel nos acompañó una vez en el terremoto de México. Y ahí hay una estrategia que se llama el peer-to-peer support, que es una estrategia de voluntarios, no es una estrategia especializada. Es una estrategia de cuando alguien vuelve de misión, hay un grupo de personas que tienen un entrenamiento de menos de un día para escuchar a alguien que llega y de hacer como un debriefing de yo lo entiendo, yo pasé por eso, estuve allí, que tiene como unas cosas más de factores de protección, bienestar emocional, para que la gente que vuelve de misión, porque hay depresión después de las misiones. Y ahí hay un protocolo que luego pasa a un segundo nivel en donde hay voluntarios, de los cuales yo soy parte, en que ya somos más especialistas para hacer más un debriefing terapéutico, psicológico, y ahí también pues remisión a tratamiento. Pues no se imaginan cómo estamos ahora con la gente que vuelve de Gaza y hemos perdido 14 compañeros gazatíes en la guerra. Entonces la gente está llegando muy afectada y aparece una crítica sobre el peer-to-peer support. O sea, aparece gente que dice, no deberían estar haciendo los colegas rasos, no psicólogos, no psiquiatras, no, con un día de entrenamiento ese trabajo. Sin embargo, yo creo que es muy importante porque cuando uno tiene la posibilidad de hablar con alguien que no es especialista, no tiene el estigma de llegué mal o estoy mal. Y esa persona lo puede entender, un poco lo que haces tú en tu podcast, ¿sí? Porque cuando la gente ya va a consulta, ya dice, no, yo ya estoy mal. ¿Qué piensa usted de esa estrategia? Porque en este momento estamos en esa discusión. Gracias.
I love your question and I love your detail. Thank you so much for that. I loved your talk this morning as well. What could I say, but I can't tell you how much I am in support of peer groups. They're so essential in our treatment armamentarium. And when or if we're not able to get our patients to go to a peer group, I don't relent. I accept now. But I'm hoping when I see them in a week or a month that I'll be able to kind of reintroduce it. There's 3 groups in particular, and you've already named such an important one. Look at the Palestinian physicians who have died, that sort of thing. The bottom line, of course, is you're with individuals who know your pain, they know your story. I mean, so the 3 that I can think of that I think really epitomize this, one is the one who I know so well through my co-author, Carla Fine. She was asked to go, because she didn't think she was going to survive her husband's suicide loss. She just didn't think she would survive. So she's been asked that. What kept you going? She said there were 3 things. One was my therapist who accepted me, didn't freak out. She accepted that, suicide's a real entity and it's awful for those left behind. The second one, she said, was writing her book, because that was therapeutic. And the third one, she said, was her suicide support group. Because she said in that group, we could finish each other's sentences. There's no judgment. She said, the only person in that room who's judging is yourself, not the others. She said, I was around people some of them who have remained her best friends. That's one group. The other is Caduceus group. That's the health professionals group of doctors or other health in recovery. They all say the same thing. I had trouble with addiction. That's why, yes, it's good to go to AA, but it's also good to go to caduceus because I'm with other health professionals, nurses, doctors, PAs, vets, those kinds of things, because we all know what it's like to have that power to be able to prescribe and to take drugs, that sort of thing. And the third group is a group called Compassionate Friends. There are so many, but Compassionate Friends, for those of you who don't know, that's a group that was set up for people who have lost children from any cause of death. And that's an amazing group of parents, or one parent, who have lost a child, and the child could have been stillborn, so that's somebody, to you're there because you're 90 and you've just lost your 60-year-old son, and you're a grieving parent, and you're welcome there. And you're also welcome there if you lost your child 50 years ago, but haven't been able to talk about it until now. So it's just like, because it's those peer things, such an important tool in our therapeutic, armamentarium.
Vale, thank you. Nos queda tiempo para una última pregunta, si alguien quiere hacerla, si no, vamos cerrando. O alguien del panel, si quiere comentar, hacer un último comentario.
Un consejo que vi en otra parte alrededor de el soporte de pares es que todo depende de cómo lo enfoque uno. Si la gente siente que uno lo enfoca es para ahorrar costos de arriba, creo que está mal. Debe ser muy claro el objetivo de esto y muy claro también el soporte para los pares. Entonces, eso creo que es clave tenerlo ahí. Otra circunstancia que yo veo en medios de comunicación que es muy importante tener en mente siempre es el objetivo final o el propósito de ese medio de comunicación. Porque conocemos que hay medios de comunicación que quieren básicamente volverse virales para obtener réditos económicos y rompen muchos espacios. Que creo yo que eso pues tiene mucho de problema. Indudablemente el de Andrea, que conozco muy bien, no tiene ese perfil. Y claramente a mí me encantaría ver ese tipo de medios de comunicación que quieran no ganar plata por esto, ni ganar narcisísticamente muchos réditos y muchos likes, que es lo que está debajo de cuerda, porque todo vale. En un libro que publicamos con alguien de Comunicarnos sin Daño, hablamos de este tipo de cosas, que creo que la comunicación con daño puede verse muy fácilmente en los medios. Y también cada vez más pues la mala información no se puede detectar y se confunde y se mezcla con muchas cosas. Algo de lo cual no comentaron y creo que vale la pena tenerlo en mente es del efecto dañino de la comunicación, el efecto Werther, que ya desde Goethe se hablaba, y de los suicidios que pueden venir cuando yo comunico mal un suicidio. Y eso es algo importante que estamos trabajando ahorita en una tesis de grado acá en Colombia para ver la magnitud del efecto Werther que existe y que sabemos de cómo comunicar. Y además en los protocolos iniciales, cuando hay problemas de suicidio en educación o en un hospital o llámese donde sea, hay que tener muy claro el ABC de qué hay que hacer, y eso lo hemos compartido con algunos decanos y hemos ayudado a algunos sitios que han tenido estas dificultades que se van a seguir viendo, y hay que saber muy claramente esto, y hay que saber también el límite, y ahí viene la compasión y la humanidad de que la familia, es decir, hay cosas que no son públicas, y llevar todo a lo público es importante. Es decir, si a mí un hijo se me suicida, ojalá no lo comuniquen por los medios, y cada uno tendrá su forma de verlo. Y ha habido suicidios en los cuales la familia claramente no ha querido eso, y se rompen esas barreras, que también creo que como que se vuelve un bien público y un bien masoquísticamente, narcisísticamente mal llevado. Muchos más apelativos podría dar. Entonces, todo eso hay que contemplarlo en un tema que, como hemos visto estos días, es un tema muy complejo, en los cuales necesitamos datos, en los cuales ojalá todas las facultades de medicina nos unamos en torno a proveer datos, porque no tener datos andamos muy a ciegas. Es decir, yo tengo mis datos personales e intransferibles de gente que me llama a solicitarnos ayuda por lo que sea. Tenemos experiencia y más estudio y más de todo en esto, y colaboramos con esto, pero claramente también necesitamos alimentarnos de otros focos. Pero esto, hay tal estigma y tal temor reputacional, etcétera, etcétera. ¿Qué es esto? Y lo que decía el doctor Myers, claramente la Javeriana y la Facultad de Medicina ha estado muy al frente de esto, y así lo han reconocido en el Ministerio de Educación, de mostrar y de liderar cosas alrededor de esto, algunas de las cuales esperamos que ayude a la población médica, ¿sí? Y hay muchas cosas que se manejan, y es también qué no hacer, qué no se debe hacer en esto, y cómo se deben manejar diferentes dificultades que aparecen en medio. Sé de Alejandro que ha manejado algunas, etcétera, que creo que son cosas muy importantes que tenemos que aprender. Y los médicos, como decían, tenemos que aprender esto transversalmente durante el aprendizaje, y lo que comentaban, que claramente lo tenemos muy, muy claro, por lo menos acá en la universidad, que esto debe hacer parte del aprendizaje curricular obligatorio. Esto no es una metástasis que es el que pueda ir, el que pueda hacer, sino es una formación en bienestar y en cuidado del otro, y en saber cómo cuidar, cómo expresar todo esto, que tiene muchas aristas, ¿sí? Y que es muy difícil, por lo que nos han comentado todos. Quiero agradecer finalmente al profesor Myers todo lo que nos dio en estos día y medio. Creo que aprendimos mucho, y a todos los presentes, a todos los moderadores, al igual al doctor Oviedo, a Natalia, por todo lo que lideraron o lideramos ahí un poco por detrás también, para tener algo así, que creo que va a repercutir enormemente. Nos dimos el trabajo de grabar todas las ponencias para tener una difusión, y que la gente y las diferentes facultades se alimenten de esto, al igual que esperamos alimentarnos de otras, como el doctor Ariel, que es compañero y amigo del alma, que ha publicado y ha hecho muchas cosas muy beneficiosas en torno a los médicos. Muchas gracias.
Sobre el comentario del doctor Gómez, es muy importante ese mensaje de la comunicación, redes sociales. Hemos hablado bastante de redes sociales y salud mental. Evidentemente, cada individuo con una plataforma, una red social, es un comunicador en potencia, con una gran responsabilidad. Y acá nosotros, médicos, por supuesto, con una gran responsabilidad en términos de salud mental. Y este elemento que mencionaba el doctor Gómez del efecto Werther, del efecto de la comunicación inapropiada, de la conducta suicida, que redunda incluso en componentes de suicidio por imitación, tiene también una contraparte, y es el efecto Papageno, tomado de la ópera La flauta mágica de Mozart, en donde hay una noción esperanzadora, compasiva, que también redunda en otro tipo de desenlaces y de sensaciones en las personas que lo reciben. Para ir cerrando este espacio, quiero agradecer a los asistentes por ese interés, por las preguntas, por los comentarios. Hay varias personas también conectadas en las redes. Un agradecimiento especial a la Oficina de Comunicaciones del Hospital San Ignacio, quien nos ha apoyado enormemente en difusión, en acompañamiento. Asimismo, a la Oficina de Comunicaciones de la Universidad Javeriana y de la Facultad de Medicina, el Departamento Audiovisual y las personas de soporte técnico que han hecho una transmisión muy buena, con una gran posibilidad de difusión, y qué bueno que esto quede acá como un legado para todos. Un agradecimiento muy especial al doctor Carlos Gómez, a la doctora Magda Alba por todos los esfuerzos y apoyo en este sentido, y poder hacer realidad tener al doctor Michael Myers y al resto de invitados, conferencistas que hicieron posible este evento en función de un tema de relevancia actual.
Muchas gracias. Me sumo a todos los agradecimientos que el doctor Oviedo ha dicho y a los panelistas por el tiempo y haber estado acá.
Recuerden que todas las charlas, los paneles de ayer y el día de hoy quedan en la página de YouTube de la Facultad de Medicina de la Universidad Javeriana para su consulta, acceso y difusión. Muchas gracias.